Okay, my name is Dr. Rhoda Kalondo from Kenyatta National Hospital. My co-host is Dr. Rosa Chemwei, and today we have a very interesting topic. We are having Dr. Agatha Olago from the Ministry of Health who will be taking us through the home-based care guidelines that the Ministry of Health has developed and is in the process of rolling out. So it will be a very interesting conversation, Dr. Olago. We had a similar presentation, but this was more of our opinion sharing two weeks ago. And the presentation was by Professor Kipto. So it will be good to see whether the sentiments were captured, and it will be good to also hear from the participants what you think about it. It was highlighted briefly yesterday in the news, mainstream news. So it will be good to hear your comments and your feedback in the Q&A section, and just to see how we can make this better. It's something we may not be able to run away from now that our health system is getting overwhelmed. Yesterday, we saw that Busia County has quite a lot of number of cases. The facility that put in place, Alupe, was already full. So they were looking into the other facilities, which were schools. And we can see the Ministry of Education is proposing to open up in September. So the spaces that we'd reserved for taking care of our patients, we might not have them for long. So this is a timely conversation, and we're very grateful to the Ministry of Health for developing these guidelines. So Dr. Olago, I'd like to hand over to you so that you can take us through the guidelines. Just remember to put your questions in the Q&A section or your suggestions. Thank you.
Thank you, Rhoda, for the introductions. As she says, I'm Dr. Agatha Olago from the Ministry of Health. And I'll be discussing the guidelines which have been developed, the home-based care for patients with COVID-19. Of note is that these guidelines have been developed already on the Ministry of Health website, but they will be, they're meant to be launched today. So we actually hope that during today's speech, the CS will be launching. So when following the launch, they'll actually be circulated and everything will be online. So we'll be discussing them, but I think for the implementation rollout actually will be following the launch. So that may actually be pending after this. Okay, so I'll just go through this. Just a disclosure that I'm not an expert. We'll be going through, I think these guidelines have been developed by quite a number of contributions from Ministry of Health as well as partners. And we have Dr. Maritin as well, who's a panelist, who's also supported the development of these home-based care guidelines. Just as an introduction, I will be going through the introduction to the guidelines, a background on this, the definition, and just looking at the Kenyan guidance as well, what it covers. As at 8th of June, we know that we are currently at 2,862 confirmed cases, and total recovery is about 849. And we know so far we've had about 85 deaths from this. And we know since we reported those first confirmed case on 12th of March, we've took quite a number of measures to contain the spread, including the face mask and the restriction of movement. And currently we have a number that is still rising. And we know that approximately 78% of those persons are either asymptomatic or mildly symptomatic. So we expect that that number will rise, given that we're in this community transmission phase, and especially as targeted mass testing continues. So all these patients are accommodated in hospitals or isolation facilities. And Rhoda has already mentioned the challenges that are being faced. You already have facilities such as Kenyatta University Teaching and Referral Hospital. We have the KNH infectious disease unit is already full. So the guidelines for home-based isolation and care for patients with COVID-19 have been developed actually in response to this. And this approach to have home-based isolation and care of COVID-19 patients is mainly to ease that growing pressure of patients within the hospitals and nationally, and it's as we are having the increased community transmission. So just as a background, I think the WHO had actually given recommendation on isolation, and they'd actually recommended that all laboratory confirmed cases of COVID-19 should be cared for in isolation. And this is either within a healthcare facility, a community facility, or self-isolation where it's possible. And we know that in the situations where we may not be able to have isolation of all cases within a healthcare facility. So it actually emphasizes that we need to prioritize those who have the highest probability of poor outcomes to be isolated within the healthcare facility. So it also recommends that safe home-based isolation and care for patients with suspected COVID-19 can be done, and that should actually be done for those who present with mild symptoms. And we need to ensure that there are public health measures which can support management of the contacts as well. So some of the definitions within the guideline, the isolation, we know that separation of the ill persons, within this case, COVID-19 from people who are not sick. And an isolation center is a designated area where persons with a contagious disease are separated from people who are not sick. So the Kenyan guidance on home-based care looks at patients' eligibility for home-based care, assessment of feasibility, procedures which should be followed during the home-based care, a referral system where when there is progression of symptoms, criteria for ending home-based isolation and care, the aspect of community participation, as well as monitoring for home-based care. So when it comes to eligibility, patients who have been assessed by a healthcare worker, the criteria which is being used is that first of all, the patient has to be lab confirmed COVID-19. They should be asymptomatic patients or patients with mild symptoms of COVID-19. I think one of the things we need to highlight when it comes to issues around asymptomatic patients is that it could be that the patient is also pre-symptomatic. So that's something that we need to keep monitoring symptoms for. There should be absence of comorbidities, and we'll look at these comorbidities. And there should be access to a suitable space for home-based isolation and care. Patients who are not eligible or who are at risk of complications are not eligible for home-based care. These are patients who have moderate, severe, and critical illness, and patients with mild illness but have a risk for poor outcome. For example, patients who are aged over 60 years. The underlying comorbidities, for example, cardiac disease, chronic lung disease, diabetes, hypertension, cancer, immunosuppression, cerebrovascular disease, chronic kidney disease, and the WHO guidelines actually adds the risk of smoking as a comorbidity for that, although this is not highlighted within the Kenyan guidance. This is just showing the disease severity of COVID-19. Mild disease, those are symptomatic patients, and I think we know the symptoms which may count as COVID-19 symptoms, mostly the cough, difficulty in breathing, and some of the other symptoms that are highlighted. This is from the WHO guidance. Moderate disease, especially where a patient has pneumonia, and an adolescent or adult with clinical signs of pneumonia, that's fever, cough, dyspnea, fast breathing, but no signs of severe pneumonia. Child who has, if it's a child who has a clinical signs of non-severe pneumonia, that's cough or difficulty breathing, and fast breathing, and or chest indrawing, and no signs of severe pneumonia. So this is just looking at the disease severity, and I just brought out the issue around the mild and moderate disease just to highlight the differences among that. So when it comes to assessing feasibility of the home-based isolation and care spaces, one of the aspects that you need to look at that there are appropriate caregivers available at home. So ideally, this caregiver should be, if possible, limit the number of caregivers as much as possible. and ensure that it's not someone who already has a chronic or an immunosuppressive disease or an illness that may cause them to have a complicated case of COVID in case they get ill. The patient should have a separate bedroom or isolation space where they can recover without sharing the immediate space with the rest of the family or the rest of the household. If possible, they should have a separate toilet and bathroom facility for the patient. Should also have available resources for access to food and other basic necessities. And the patient and other household members have access to appropriate and recommended PPE. At a minimum, they should have gloves and face masks. The WHO actually calls for medical face masks, recommends for medical face masks. When it comes to assessing feasibility as well, you need to, there should be capability to adhere to the precautions recommended as part of home-based isolation and care. That includes the respiratory hygiene, ensuring that they follow the cough etiquette and as well as hand hygiene. So this one will be as per the infection prevention and control guidance which have been released previously and I'm sure have been discussed in this forum as well. There should be availability of a thermometer, possibly single use and not shared with other persons in the household, and a person who's able to read and record the temperature. Ideally, the patient can do that themselves, especially since they're meant to be stable as they are being put they're under home-based isolation and care. They should be able to do it themselves. And there should be no household members who are at a higher risk of complications from COVID-19. So the people over 60 years old, older persons, young children under 2 years, pregnant women, or people who are immunocompromised or have chronic heart, lung, or kidney disease, which may lead them to have severe disease from COVID-19. So some of the procedures, actually, we'll just highlight some of them, but they're quite detailed in terms, and they'll mainly refer to a lot of the guidance which have been given in the infection prevention and control guidance. They should have a dedicated and separate, well-ventilated isolation room. Should have open windows to ensure ventilation. The movement of the patient within the house should be minimized. So they need to be getting the resources, and that's why the aspect around even access to food is important, because the movement within the house will be limited. And time spent in shared spaces such as the kitchen and bathroom should be minimized. All those shared spaces should be well ventilated, and especially as regards hygiene, should ensure that cleaning is taking part after very often. As I mentioned before, limit the number of caregivers, assign one person who is in good health and with no underlying chronic or immunocompromising conditions. No visitors should be in the isolation room except for the caregiver where necessary, until the patient has completely recovered, has no signs or symptoms of COVID-19, and has tested negative as per the health protocol. So hand hygiene should be performed after any type of contact with the patient or their immediate environment. And what is recommended is that after washing hands with soap and water, it's recommended to use the disposable paper towels to dry hands. If this is not available, you may go ahead to ensure that you can use the cloth towels, but this should actually be disinfected after use, cleaned, and ensure that this is disinfected after use. Adequate disposal of those should be ensured as well. We need to also avoid other types of exposure to any contaminated items from the patient's immediate environment. So here, encourage that there should be no sharing of toothbrushes, cigarettes, eating utensils, dishes, drinks, towels, washcloths, or bed linen. And there's actually more detailed guidance on the cleaning of these items within the infection prevention and control guidance, as well as even home-based care guidance, which had actually been released earlier as well. So a face mask should be provided to the patient and worn at all times. I know what is in the WHO guidance is regarding a medical mask, the surgical face mask, which is preferred. But within the Kenyan guidance, there's also the possibility of using the cloth mask as well. And this should ensure that the the patient also knows how to clean the cloth mask, and these guidelines are also on the Ministry of Health website as well as regards the cleaning of the face masks. Ensure that they're cleaned with detergent as well as disinfected with the bleach solution as well following that. Materials used to cover the mouth and nose, including the face mask, should be discarded or cleaned appropriately after use. And discarding, when it comes to discarding, we need to ensure that this is also termed and put as infectious waste and discarded appropriately, should not be mixed with the other waste for the household. So caregivers should wear a face mask that covers their mouth and nose when in the same room as the patient. And we need to ensure safe handling of face masks. And especially before putting on the face mask and after, should ensure that the patient and even the caregivers carry out good hygiene, hand hygiene as well. So you need to avoid direct contact with body fluids, particularly oral or respiratory secretions and stool. And you should use disposable gloves and a mask when providing any care, especially oral or respiratory care, and especially when handling any stool, urine, and other waste. So make sure that you perform hand hygiene, as I mentioned, before and after removing gloves and the mask, and single-use gloves should not be reused. So for the patient, you should use dedicated linen and eating utensils, which should be disinfected with 0.5% chlorine bleach immediately after use by the patient. And this should be cleaned with soap and water. Utensils and some of the linen can be reused following that. So what is recommended, I think just like what was happening within some of the quarantine sites as well, is that the patient should be engaged in the frequent cleaning and disinfecting of surfaces that are frequently touched in the isolation room. And that includes the cleaning of the bedside tables, bed frames, and other bedroom furniture. So they should be cleaning the inside. I think this is actually just meant to reduce increased contact of the caregiver with any surfaces which may be infected. Regular household soap or detergent should be used first for cleaning, and this is emphasized within the infection prevention and control guidelines as well. And then after rinsing, regular household disinfectant with 0.5% bleach can actually be used. Okay, so bathroom and toilet surfaces, especially where they're shared, should be cleaned at least twice daily. And I think as we highlighted, linen should be cleaned thoroughly, and any contaminated linen should actually be put in a laundry bag to just avoid contamination. In case of any soiled laundry and contaminated materials, they should not be shaken so that's not to spread any of the contagion, and also should avoid coming into contact with skin and clothes. So a lot of the education, especially regarding protection, and is actually mainly going to be to the caregivers. We need to give a lot of support regarding education around hand hygiene, around safe use of the face mask, gloves, to the caregivers, especially as we are considering this home-based care. We should try and have heavy-duty gloves and protective clothing. For example, plastic aprons being used especially when cleaning surfaces or handling clothing or linen soiled with body fluids. And ensure, as before, has been emphasized before.
Oh, sorry, we apologize for the internet issues. Give us 1 second to sort it out. We apologize for that.
Yeah, so we get our truth on the other side because that will get them to complete.
No, we don't have to get it completely. Is what Itarudi? Imarudi. Let me connect that and then as a backup to my phone.
Okay, apologies. I think the internet had gone off. I hope you didn't miss much, but I think if you realize the procedures are mainly details which are also included in previous guidance issues, and they're really mainly stressing around hand hygiene, especially with use of gloves, protective clothing, and especially ensuring that there's safe disposal of waste, whereas you have, where we have the home-based care. So isolation should be maintained for at least 14 days from the date that the patient is assessed eligible for home-based isolation and care. And this isolation period should be maintained even in the absence of or after resolution of symptoms, or until advised by the healthcare worker who's in charge of the site, especially in the event of that a patient continues to have symptoms beyond the 14 days. So that's something that will need to be discussed case by case basis. So one thing that's coming out is that we'll need to ensure that it's a case by case evaluation of clients who should be within the home-based care or isolation. This is just from the WHO, which just highlights home care for people with suspected or confirmed COVID-19. And it mainly even helps the caregiver to see what needs to be done. And I think we also have one which has been developed by the MOH to be able to circulate it following the launch with all the guidances available. Ensure that the ill person rests, drink plenty of fluids, and eats nutritious food. Frequently clean hands with soap and water or alcohol-based rub, especially if there's any contact with the person when preparing food, before eating, and after using the toilet. Ensure that any frequently touched surfaces are cleaned and disinfected, even more than once daily. Having a medical mask, that's from the WHO, but here we emphasize on a mask. So cloth masks are still, can still be used. Using dedicated dishes for the ill person, and ensuring that they're cleaned well with soap and water, and even disinfected later with a bleach solution. And the most critical part is that how to respond, especially when a person worsens, that you need to call the healthcare facility immediately if the ill person worsens or experiences difficulty breathing. So what we have as a referral system for the patient if progression of symptoms is noted. So if there's any queries or worsening symptoms, we advise to call 719 or send a short message to *719#. And the patient or caregiver should also notify the designated healthcare worker where this is available, where there's a designated healthcare worker or community resource person. So the healthcare worker will then assess the patient and take appropriate measures for referral if necessary. Whereas a caregiver or household contact developed symptoms of COVID, caregiver should also notify the designated healthcare worker, who will then notify the rapid response team, and all counties have these rapid response teams in place within the jurisdiction. The rapid response team will conduct an assessment and recommend the necessary measures, including testing and how that should happen. The contact should avoid taking public transport to a health facility, should observe physical distance, respiratory, and hand hygiene. And while on home-based isolation and care, all the household contacts should fill the symptom monitoring schedule for the 14-day isolation period as part of the Jitenge monitoring system. When to end the home-based isolation and care, so for asymptomatic patients, at least 14 days have passed since the date of the first COVID-19 test, and they have not developed symptoms since the positive test. For symptomatic patients, they've had no fever for at least 72 hours. That is 3 full days of no fever without using medicines, any medication that reduce fevers, and other symptoms have improved. For example, in case there's cough or shortness of breath, that has improved, and at least 14 days have passed since the symptoms first appeared. If there's testing available, then isolation can stop after 2 consecutive negative tests, 24 hours apart. So the Jitenge system, I think you mentioned that this approach of home-based care is Jitenge, keeping apart or isolation. So the Jitenge system is an at-home COVID-19 short code and text message-based system for the purpose of monitoring household contacts, the isolated patient, and post-isolation discharged patients. So this, once the guidelines have been launched, this will be used for monitoring the clients. It's previously been used for clients who are in quarantine, but now to be used for clients in isolation and care. So there'll be weekly reports from the healthcare worker who is in charge of the isolation homes, apartments, or institutions, which will be uploaded to the Jitenge system, from when the reports will be accessible to county and national rapid response team for any further oversight and action. Where necessary, you may have home visits by the healthcare worker. The healthcare worker should also submit a monthly follow-up report on discharged patients from isolation facilities. And this report should be reaching the Ministry of Health, KHIS, the Kenya Health Information System, by the 5th of every month. So when it comes to support structures for this home and isolation, home-based care and isolation, I think one of the critical parts, especially where we have the functional community health units, will be the community health units and the community health volunteers. They'll be involved, especially for the assessment process for eligibility for home-based care. There'll be a communication link between the healthcare worker and the household, as well as supporting for monitoring. And this will be under the supervision of the healthcare worker or the community health assistants. In informal settlements where it's not possible to consider the home-based isolation and care, and you know that households share small spaces, the communities will need to identify an institution that meets recommendations suitable for providing care. And this has actually been, this is part of one of the suggestions which actually came from the community units which are active. In rural setups, the Nyumba Kumi initiative will support care in the community. In areas where majority of people live in apartments, is actually going to be support of the committee members managing the area, or in the welfare committees for the area, who will be sought together with healthcare worker, as well as friendly security. So it shouldn't be policing or managing people in that aspect. The patient and household members should be provided with ongoing support and education. And this is one of the most critical aspects that the health promotion officers or healthcare workers will have to play a big role in. These are just showing what parts the community health workers have been playing, especially within the COVID response. We know they've been doing quite a lot as regards reaching out to the communities and educating them and ensuring that we have hygiene aspects in place. When it comes to the home-based isolation and care monitoring tools, within the guidance, we have a daily monitoring form, which mainly actually has details of the temperature and any symptoms which the patient has developed or may develop on the course of the isolation period, which is the 14 days. There is a checklist for assessment of environmental conditions for home-based isolation and care of persons with COVID. So it looks at the infrastructure, where the patient will be, the home-based isolation should take place, accessibility, accommodation, resources, as we mentioned, the aspect around even access to food, which is needed. So, and even water, clean potable water for drinking, and even clean water for use in the household, whether they have access to such. So this is considered within the checklist for assessment of environmental condition, as well as primary care and support. Is there a linkage to a healthcare worker? Is there a linkage to a community health unit within that? And then there's also a consent form for COVID-19 patients who meet the criteria for home-based isolation and care. So we'll also be able to send some of these documents forward. So a lot of the main references from these updated home-based isolation and care guidelines for patients with COVID-19, June 2020, I think it's within the MOH website. We've also referenced from the interim guidelines on management of COVID-19, as well as the infection prevention and control guidelines as well, and the WHO guidelines regarding to home care, as well as on clinical management of COVID. So thank you very much for listening. I think now we'll be able to take some questions. We can go ahead. We can go ahead with the questions on that.
All right. Thank you so much, Agatha, for that clear presentation. We appreciate that you found time to come and share with us the guidelines. And you brought out a very pertinent issue about housing and housing being a determinant of health. It's one of the key determinants of health, and there are issues that maybe we might need to address before we roll this out. They might be beyond us, but there are still issues that will need to be addressed. As we talk about the criteria that you've given for home-based isolation, I'm just thinking about overcrowding, sanitation, inadequate ventilation. I'm thinking about waste disposal. We already have that as a big challenge in our community, not just in Nairobi, even out there at the county level. We have issues of challenges with water. Like yesterday in the news is when we saw now we're being told water has been restored to Nairobi County and its environs after almost more than a month of areas lacking water. So those are things we need to address. And it's also an eye-opener to us as healthcare workers that there's an area probably where we've not been giving our input in. When it comes to housing, we might not have been very much involved, or maybe the public health is involved, I'm not aware. But we need to get more involved in determining and advocating for healthy and affordable houses. We need to be more involved in assessing the housing conditions. And we need to also look at accessibility issues. So as the Ministry of Housing, approves some of these plans, the County Council approves the plans for building. Maybe it's about time we put in our voice so that when we are faced with a similar situation like the one we're going through right now, we don't have guidelines that only favor a particular area of the town and the other area of town cannot be party to these guidelines because of the challenges with the housing that they have. So I'd like to request Dr. Rosa Chemwei to take us through the Q&A session. Dr. Maritim, sorry, before we go to the Q&A, Dr. Maritim was also part of the team that developed the guidelines. Maybe you can give us an input into this. What do you think about these guidelines? Do they favor particular areas or towns, particular towns, and others are not able to meet the threshold for these guidelines to be rolled out? Dr. Maritim? Okay, as we wait for Dr. Maritim, we can hear from Professor Duarte. We can hear a few sentiments. You can share a few sentiments with us, Professor.
Yeah.
Prof, let me talk first before you. Prof. Duarte?
Oh, okay. Yes, go ahead.
I was struggling with my microphone. I'm in transit, but I'm able to join the meeting. So just to add a few things before Prof. Duarte talks. So these guidelines have taken long. The process to develop these guidelines has taken long. It's been a consultative process, and we totally understand that these guidelines may just cater for a small proportion of people currently affected by COVID-19. And even when we had the discussion 2 weeks ago, that became very, very apparent because a lot of our patients currently that we have come from the informal settlements where people live in a one room, and therefore the thought of home-based isolation will not be possible in that setting. So that is one thing I want to mention. The second thing I want to mention, these are the first guidelines. We have a chance to sort of pilot these guidelines and use what we learn from this pilot to help revise the guidelines at the earliest opportunity. So in this, within this 30 days or in the, already we have started the process to see how to implement these guidelines and to really tweak them to see what needs to be done to make them more feasible to implement. Because as they are written now, even implementation may be a challenge, and particularly the ideal isolation facilities at home to prevent clustering of infection within the household. So that is one of the things we are really cognizant about. To address the first thing that I mentioned, where many people may not be eligible, we are looking at possibilities of community-based isolation facilities that take care of people in the settings close to where they live, but in a safe manner, where people can be cohorted together and looked after in that setting, bearing in mind infection prevention within that setting, community ownership, community owning that process. So that is work in progress. When it comes to the other aspects of, I saw a question about the psychosocial aspect. Maybe that could have been overlooked, but the 719 number links up with 1199, which are hotline numbers that provide psychosocial support for people. So these hotlines that were already identified as part of the initial response to COVID-19 are not being replaced and will still be available for a large proportion of patients that need psychological care. So we should not forget, we are not putting home-based care without systems. So the systems that already exist will support implementation of home-based care. And this includes the 719 hotline number, as well as the 1199, which is a hotline number for psychosocial support. So those are my comments at this point in time, but will be available to respond to other things in the Q&A. Thank you.
Thank you. Thank you so much, Dr. Maritim, for that clarification. Professor Ndwati?
Yeah. Thank you very much. And Dr. Agatha, thank you for a very clear presentation on this, I think, very difficult matter. I have a couple of observations. First, let me just say that home-based care as having a person with a highly contagious illness in their home, in their house, in an isolated room, in my mind, doesn't fly. I think that's a problem. And I want to draw your attention to actually a couple of publications, one from this year, and the other soon after the last SARS epidemic. And it talks about the ethical and legal challenges and obligations that a government has. In the context of Ebola, we are looking at a disaster. A disaster on a scale that we still are not able to comprehend. And when you have the situation, it's very important that you balance, you have a clear balance between what is public good and individual good. One of the criticisms of the Ebola outbreak in West Africa was that governments prioritized individual good. So the focus was on treating the person, the clinical trials and all the rest of it. And there was less attention on the public good. And as a result, you had a terrible epidemic with incredibly high mortality. I don't know whether you have actually looked at these guidelines in that context. What the guideline you're putting in is one where you're pampering the individual's needs at the cost of the public good. My second observation is that if you look at our Kenyan situation, whether you're high socioeconomic or low socioeconomic, care providers are usually women and girls. And the AIDS epidemic, showed us that when somebody was sick and in trouble, it was their sister, their mother, or their wife who was there caring for them. So this guideline is actually one that will pamper the men, but will be a terrible experience for the women. I don't know whether you've looked at it from that lens of gender, what it really means to say you're taking somebody home for care. Now, my third observation is that, in fact, I would even say this, Dr. Olago, even as you are planning to have this launch today, that you actually should consult with the Office of the Attorney General. A disaster of this scale, the obligation. Sorry. Mary Beth, we can hear you. A disaster of this scale. Mary Beth, a disaster of this scale, where you're dealing with an illness that results in death and in fairly high mortality in some of the.
I'm so sorry. I'm sorry. I apologize.
It's okay. Okay. There's an obligation of the government. One of the obligations of the government is to do their very best to protect the lives of Kenyans. Even if we are out there saying Hakietu, we are community, we are self-determination, the final obligation is to the government to protect its citizens. I'm not sure this guideline actually meets that threshold. That you can, even if you're only talking of household transmission, you're not meeting that. It's not meeting that threshold. Eh? Then my fourth point is you had that whole long list of what is good nursing care for an individual who has a highly contagious disease. We are not meeting even that minimum in our own facilities. You walk to any of these health centers or even district hospitals, and you'll find health workers are not meeting that minimum as they provide care to the public. So I'm wondering, how are you going to achieve this with an individual who doesn't even have a health training background to be able to go home with their relative who is asymptomatic? There's also the observation that people at the stage where you're pre-symptomatic, asymptomatic, that's when you have the highest virus shedding, so the highest potential exposure. We don't know about adherence, to all the things that we have said about prevention. And so really, my take is that my take is that this is not a good plan. My take is that the ministry needs to discuss this also with the Office of the Attorney General about what are the legal obligations when you put a guideline that may cause actual harm. My third take is that you need to ask yourself, where has it worked? And my fourth take is to caution you. WHO has put a lot of guidelines, and many of them, we love them. But in this particular epidemic, I think they've been behind the curve. They're actually making guidelines that they're sort of playing catch up. And there are many circles where we are not sure that this spread of this pandemic wasn't part of that slowness and playing catch up in terms of recommendations. So I would not put that there as the reason for adopting a guideline. Even that flyer that they have put there, the person who's the care provider doesn't have a mask. So if you put that flyer out there, the message is you don't have to use a mask. And yet you need a mask for both the patient and the care provider. So that's my sort of initial take on this particular guideline. Yes, one more thing. I think Dr. Correa flagged off something, and I agree with her. The disease progression of for corona, the people who go down can actually go down very quickly. You have people who come in, walk into a hospital, they are looking well, and they have oxygen saturations down into the 50s. Now, are you going to have a pulse oximeter to monitor that? And then, of course, in this guideline, you have not talked about how will you manage the deaths at home, because once you go this way, there will be people who die at home. Do you have a system of supporting that as well? So those are sort of my take on this guideline. Thank you.
Thank you so much, Professor Ndwati, for your input. We've had, from your comments, we've heard about the ethical and legal challenges and the obligation the government has, public good versus individual good. What are we choosing in these guidelines? We've also had you highlight very clearly about gender. It's true, most likely women will end up being the majority of the caregivers. So that is an issue that you brought up very clearly. And the issue of minimum requirement for care or of care. And the highest viral shedding, when you talk about pre-symptomatic, asymptomatic patients, how do we manage them? Then you brought out a very clear point about having a robust healthcare system, whereby the community health worker, as much as we are using them as our point person in rolling out these guidelines and enforcing them or implementing them, we are also educating them, and we're making sure that they understand. It may not be easy for Dr. Olago to address some of the issues that have come up. There are quite a number, but we'd love to hear your comments. So she's taking note of them. Some she will address. So let's compile a few of the questions or a few of the sentiments, and then she'll be able to address most of them as together. But thank you so much, Professor Ndwati, for your input. We hear you very loud and clear. And those are key areas that we need to address before rolling this out. So I'd love to hear from Professor
Hello.
Anzala, who raised his hand. Yes.
Dr. Kalundu.
Yes, Amina.
Hello.
Hello.
Can you hear me?
Yes, I can hear you. Go ahead.
To raise a few issues of concern. Maybe Dr. Agatha can answer me.
Okay.
The quarantine centers, are they being shifted to be like the community area? Are we going to still quarantine people? Because I'm thinking before the home-based care, maybe we could have started by putting the positive in the quarantine facilities, because I believe their capacities are high as well. And specifically for Kibera people, because we get a lot of positives from Kibera. And unfortunately, from the criteria that you have clearly shown, majority of them don't fit. They would simply go about their own business, because they don't even have money to have day-to-day food and everything of that sort. And then another issue that I would really like to understand is the issue of transport, because the numbers are spiking, and ambulance services, will they be able to keep up with this? Are we having alternative modes of transportation for these people? Like if we discover they're positive and they're not in a hospital, or they're in somewhere or anywhere else, how are they supposed to move from point A to point B? Those are the main issues that I wanted to address.
Thank you, Amina, for that input. Dr. Agatha is noting them down. She will address them. And I want to echo again the sentiments shared by Dr. Maritim. They developed this as a team, and they're building it up. Once they start rolling out, they'll build up once they identify the gaps. But there's a very interesting comment from Dr. Irene Mukui. And she's saying the devil is in the details of how this will be implemented. And that's the sentiment we're getting from most of the people. And how well the monitoring will be done for home-based care. One, to determine the appropriateness of care, and to pick early signs for the need to transition to hospital care, should there be need. Thank you for that, Irene Mukui. Professor Anzala, would you like to give an input to this conversation?
Yeah, Professor Ruth Ndwati, thank you, for being there, and all the rest. These things are not easy. Ruth, I heard you, and I've heard you very well. And as we were preparing this document, really, these are the difficulties we are going through. Because the home-based isolation, personally, I'm not calling it home-based care. I'm calling it home-based isolation, has been, an issue that has a problem, because first of all, we need to borrow from the natural history. What is a natural history of this infection? We know this is a highly, highly contagious disease. It's also clear that there's a prodromal period where it's like pre-asymptomatic, where people are shedding virus. But also, we are also being informed very, very clearly as we look at the natural history, that there's a large segment of maybe 80 to 90% of confirmed positives that go through the 14 on the 21-day period completely free of any major symptom, maybe just a little cough and a fever. And you saw videos of some of these guys having fun at KU. So we are beginning, and the costs involved, I'm surprised people have never really looked at it, but the costs involved are huge. So the issue is that after understanding the natural history of our own in this country, looking at so far the number of patients who have come through, so what will be the middle ground? And how do we ensure that we can home isolate without clustering at home and infecting everybody at home? And hence this guideline. I agree with all of you, it is not easy to implement. In fact, our position to the government was that, can we pilot a little bit in Nairobi and Mombasa? I don't know whether Sud is on the line, but already Mombasa had started a bit of home isolation. But can we pilot a bit of it in Nairobi and Mombasa and try to understand? And then there is the whole issue of won't home isolate, can't home isolate. And that's where we are coming in with a middle ground of community isolation. Community isolation. And community isolation, again, will be a middle ground in between. So that we only put individuals at hospital facility, those who actually deserve to be there, and those who actually need healthcare intervention. Those maybe who might end up with moderate, continuously to severe disease. The thinking is informed by that aspect of natural history. So we want to pilot it out. So then the issue is that we know very well that pre-asymptomatic, asymptomatic, so moderate, severe, all these things is not clear. I wish I had a biomarker to say that I have identified this particular individual is confirmed positive, but because of this biomarker, they'll never progress. We don't have that. So we are working from that point of view, is that we want to pilot, have facility isolation for those who actually are coming down with disease, have home isolation for those who are capable of, and the checklist is there, and they can actually be mandated to stay at home because there's a tag we are looking for that can actually be tagged. These individuals can actually be tagged and they can be monitored from a central place to see that they are actually at home and they fulfill all that criteria. Those who can't and won't, then we go into the middle ground of community isolation. Then there was so this is the thinking. It's not easy, ladies and gentlemen, because of the nature of the contagious. But if we could pilot it as we have suggested in Nairobi in the next 30 days and find out what is going on, then we can begin slowly to roll it out. We can also try to understand how Mombasa has done it, because Mombasa, from my understanding, has actually attempted home isolation. And then differentiate quarantine and isolation. Quarantine are for contacts. These are individuals who have not been confirmed yet. So the quarantine centers will actually continue because these are actually contacts who are awaiting confirmation whether they have COVID or not. So this is Ruth and the others who are on the call. This is actually the whole process we are trying to do because of the costs involved in terms of putting individuals in hospital facility, and these individuals is almost just like a lodging because they actually don't need any manner of healthcare. So that is the discussion we want to have. Can we pilot? And if you're going to pilot, what do we do? And also the ability to train at home, and even maybe ability to give these guys at home a pulse oximeter to be able to also maybe just, if conditions change, then how quickly can we move them? And what do we need them to monitor at home when they are there? These are the kind of things that we are thinking of as we begin to pilot. But I wouldn't suggest that we roll this thing out immediately as it is. Thank you.
Thank you, Professor Nzala, for that input, and I agree with you. Clearly from the guidelines, we cannot roll them as they are, but let's hear from Dr. Agatha.
Dr. Kalondu, can I say something before Dr. Olago, because she's the owner of the project. Eh?
Yes, you can.
Prof. Omo, I appreciate what you're saying. I think the step should be, if we're stepping down from the hospital, we should go to an isolation unit within the community. We should not be going home.
Mm-hmm.
Most of you have employed a domestic worker, and you know how long it takes you to train them so that they even observe basic hygiene in the house. We are now relying on training community health workers who are not health workers. They are their auxiliary staff, and then we expect them to go and transfer that knowledge to the people at the household level. I think that's a very weak link in the chain. We have many community institutions within within our communities. We have churches, we have schools, and particularly boarding schools already have rooms and beds and whatever. I think those are some of the resources that we should use for as a step down from a hospital facility. I agree that a patient in a hospital bed, is expensive, and we need to have a step down. But that step down, going to the household, is even more expensive because you will generate more cases. I've been reading history, and I was reading about the 1918 flu epidemic. In there, my home county of Nyeri, they had 17,000 deaths. You know, I know there's that discussion of how we are modeling and all that, but this is 100 years ago when they didn't have the resources and the knowledge we have. We are now sending people back home. We say, yes, we are providing these resources, but I don't see how you're going to train. You're training somebody to be like a health worker in 1 day or 2 days to do it. I don't think I think it's a very weak link in that. But I urge you, put this protocol through ethics so that you have an independent, because really when you're saying you're trying it out, is essentially a research project, because we don't know anybody else who's done it and done it well. So put it through a national bioethics review, but please also consult on the legal implications of it. I see that you have talked about informed consent. Who is giving informed consent? You know, here in a situation, you have the person who is not sick, who is a household member, and you have the person who is sick, who you're dealing with. I may not give consent for a person with a contagious illness to be nursed home at home here. That person may give consent to come and be nursed here. So I think it's not. I feel this document is not ready for launching. And when we also know how corruption is in Kenya, I can see people just bribing their way to be certified that they can do it because it's convenient to be at home, and not really follow all the steps that have been put out there. Thank you though for allowing me to speak on this matter.
Okay, thank you, Professor Nduati. We hear you, and we agree some of our systems might not be fully robust to handle this. Let's hear from Professor Guantai before Agatha addresses.
Sorry,
yes,
one more thing.
Yes.
Why people pay for the national health insurance? I mean, we pay our health insurance. Why is the insurance not paying for some of these hospital costs? It's an illness. You go on, just like any other.
Yes.
Yeah.
That's true.
Okay. Ruth, we hear you. You see, the whole aspect is that I know it is true where some countries have tried home isolation with difficulties. But what we are also saying is that this document, we have worked on it as a very big group. I can also assure the audience that we consulted widely. We actually had community advisory boards. We talked to community advisory boards and issues, and that's where the issue of community isolation came in. And what we are also trying to do as we try to pilot this is that aspect for people to also, the citizens to also understand that we can manage this. We should not fear, we should not panic, and we should not have stigma. So as we do this, these are the aspects we want to do. I know, Ruth, you are concerned, but we were made to understand that government has invested heavily in community health workers who are already dispatched, and they are already doing work in the various communities where they come. And these are the community health workers that will work.
They are not trained for infectious disease. They are not trained for this. That's not what they were trained for. And I don't think you should get hijacked to the story of looking for jobs for community health workers and we make a decision like this. We're not.
Ruth, I hear you.
I think we should not put it. Yeah. Right? They were not trained for this is like remote nursing. Yes, the person is well, but the person they transmit to is not necessarily going to get a good outcome.
Thank you, Professor Nduati, for your sentiments, and we agree this should not be used.
For a while and allow others. Okay, let me stop here for a while.
All right, thank you, Professor Nduati and Professor Nzala, for that very interesting conversation. Before Agatha addresses some of the Q&A, maybe we could hear from Professor Gwantai. Hello, Professor Gwantai.
Yes, hello.
Hello.
You can hear me?
Yes, we can hear you.
Okay. Now, I think I admire the very a very rich exchange between Professor Duat and Professor Ansara. That is very healthy. It enriches the processes that we are discussing. One of the issues that I wanted to raise has been touched on by Professor Duati, and this is the issue of giving consent. I think it's important for us to look at the patient, the sick person that you want to send home for home isolation, and let this person be part of the decision-making process in terms of giving consent. And remember that this person is going to be in a household with people that will take care of him or her. And therefore, those other persons at home should also be part of the decision-making process, so that eventually when this person is released to the home for care, everyone has bought into that decision. I think that is very, very important. And it's not just, this decision should not just be made by word of mouth. This must be properly documented and signed, so that in the event that things go wrong, we can be able to trace back the steps that we followed. Number two, when we talk about the community isolation facilities, we should actually now be looking at what is it that is required to establish those community-based facilities, who will run them, what is their training, how shall we provide the catering services, how shall we do the waste disposal, how shall we be able to respond to emergencies in case some of the patients start deteriorating. And it is like actually setting another small hospital within the community, because you are dealing with sick patients or sick persons, and you never know how the condition might change in due course. So that one we must look at very, very seriously. And I think although we want to decongest the hospitals, we should not rush into making decisions that will backfire on us, because it is expected that at our level and with the expansive consultations that we have held, the kind of decisions that we'll eventually make will be high priority policy decisions. So let's think through that process. Now, my third point is that it's good to come up with guidelines. I think that is the best way to deliver service, but the implementation of those guidelines is where the rubber meets the road. Now, when you come up with a list of the requirements to deliver the home-based isolation, what is the input of the government in terms of resources that will be made available to the homes that will host these patients, and how much effort will be put into the training of the persons that are going to take care of these sick patients. And now, the other thing is, will we have a team of trained persons that will go to those homes and check whether the homes have been prepared in readiness for receiving the patient before this person is released from the hospital. So these are issues that must be done before we release any of the patient to the home-based isolation facilities. those are the few comments that I would like to make as of now. Thank you.
Thank you, Professor Gwantai, for your input and for your questions. Dr. Agatha, would you like to address them?
Okay, thank you very much for the comments. I think a lot of them, are more of suggestions, especially on implementation of these guidelines. And I know that's the challenge. I think what Prof. Gwantai has mentioned is actually the aspect of implementation is the most critical part of this. And I think Prof. Anzala also really highlighted that, and Dr. Maritim actually highlighted that these have been developed, and we really wish we had more time, I think, for piloting and taking things as necessary. But as I think has been mentioned earlier, and I think why even this guidance came about, we've had a lot of feedback from the public. There's been a lot of communities and public engagement, especially regards this. There's been a lot of feedback, especially regarding the aspects around isolation within the facility, the hospitals. I think if you've heard about isolation in the hospitals, especially for first those asymptomatic patients. And we really understand, I think, especially being in this forum, we understand why that isolation within the hospitals had to happen at that point, especially as regards patients who are symptomatic, really do not feel the need to probably stay within would not feel the need, especially to stay within the surrounding, would not feel the need to self-isolate. And that's the need for being within the health facilities, especially. But currently, I know we already have a challenge. I think, example, in Nairobi, the facilities already being full, and we already have clients who are unable, who have COVID positive, and there's no space for them within these facilities. I think the challenge cannot be stressed when it comes to that aspect. So we're already at that point where we need to be thinking, what next? So there are already patients who are isolating at home, not by choice, but because they have nowhere else to isolate within the health facility. So the aspect around the community-based facilities is actually a very good one, and that's something that was actually suggested by the communities themselves. And so there are actually discussions around how to try and implement this, because that's actually the next best step that you can go to. Home-based isolation, I think we all agree that's actually more of a very ideal situation, but it's something that we need to try. And that's something that's actually one of the feedback as well that came from the public. So that's just to mention why some of these some of these guidelines actually are being brought out. There's an issue that came about around including pulse oximetry. We know that actually would be the best case scenario if you're to have monitoring at home with a pulse oximetry. Especially for the guidelines, especially even the WHO guidelines don't recommend having to have a pulse oximeter at home, but you're well aware about how fast actually patients can progress. So in this scenario, I think the best thing, especially for progression of cases, one thing that we really need to highlight is that progression can actually be fast. And in case of symptoms, especially if a patient has having the symptoms that are a mild case, and they start to have any of the worsening of symptoms, that's actually one of the first cases that you need to ensure that there's referral to the health facility. There's a question regarding age cutoff for children who can be home isolated. Also, that has not, I think the WHO guideline had actually mentioned 2 years, but I think that one, we have not highlighted the age cutoff within the Kenyan guidance for that. As well, I know one of the main things I think we really need to specify the issues around asymptomatic clients who are either pregnant, patients with the comorbidity but asymptomatic, and you've mentioned especially patients who may have controlled comorbidities. I think one of the critical parts we need to ensure that if we can actually have a case-by-case evaluation of these people, and that has to be in place before even a patient is being assessed. So those are some of the aspects which are being assessed, and there's the checklist actually details all those aspects that you're bringing about. is there access to these thermometers? Is there access to person? What is the health of the person? So there's a lot that is within the checklist, which we may not be able to go through at this point. But there's actually a lot of support as well in regards to the healthcare worker who's designated to that case or even to the area. So there's a lot that can actually be, that will be brought about even when the guidelines are being disseminated or being implemented in certain areas. And this is something that is being done as well at the county level. I think that has been brought up, that it will be used by the sub-county. Those rapid response teams will be the ones who will be designating these healthcare workers. So it's something that will be happening within that area that the client is. So it's actually localized to the area where the clients are. The health workers doing the assessment, certainly not limited to just the medical work, has not been specified. I know we have quite a lot of public health officers, health promotion officers, social workers who actually be supporting to do the assessment. Okay, I think, there's some issues which have been brought about, especially in regards to safe disposal. True, we're having challenge, I think, even now with the discarding of face masks, but also we still have ongoing campaigns also trying to ensure that people also dispose of the waste disposal well. And we know that some of these challenges, access to clean water, safe disposal of waste, is something we can't surmount immediately, but it's something that we're really trying to stress and work together with other ministries as well as regards this. There's an issue around stigmatization, and it's true. There've actually been public address campaigns being carried out, especially trying to target the stigmatization. I know this is something that would prove a challenge, especially to home-based isolation and care, especially for clients, and it's something that's being addressed even for healthcare workers as well. There are actually guidelines for community-based care, especially within the COVID pandemic, also available on the Ministry of Health guidelines. So I think you can actually check on that.
Okay,
Yeah.
thank you, Dr. Agatha, for addressing a few of the questions that we've seen in the Q&A section. Anyone with a burning question or concern?
So, Dr. Kalundu, allow me to mention something about the Jitenge app a little bit.
Okay.
So the Jitenge app was developed and was used during quarantine. It's an app that somebody downloads, and they're able to, it has like the form as indicated there, which has a 14-day monitoring period, and it's linked directly to the EOC, or has been linked to the EOC. So as we think about implementing it, even for, it's been developed by mHealth and other partners. And as we think about rolling it for home-based care, we are looking at a situation where counties will have their surveillance officers or epidemiologists have access, and therefore they can use it to track the people under home-based care in the various counties. There was a question that was raised by Daisy about the rapid response team, and currently it appears that it's a national response, but we know that there's a meeting today with all the governors, and probably one of the expectations is that all the counties will have systems that are in place that are identical across the 47 counties. So having a number of rapid response teams, having county hotlines, you know, having people who do contact tracing within the county, so that for the counties that already don't have this in place, it will be one of the requirements that they set up that. So even when you're talking about the rapid response teams, it will not be the national rapid response teams, but will actually be county rapid response teams. There'll be county hotlines that receive the alerts, and the investigations are investigated within the counties. Isolation hospitals are developed within the counties. Even management of patients under home-based care will not be a national function, but will actually be a county function. So even as we use the Jitenge app, it will be sending data, real-time data to the national EOC, but the county systems will also have access and therefore will be able to monitor people under their jurisdiction for the period that is indicated in the home-based guidelines. So the app will be used by the counties to monitor these people, the community health volunteers that will follow up these people, and even the public health officers, the social workers, the surveillance officers will be from the county. So even as we talk about this, this will then be disseminated to be implemented at the level of the county level, so that it's not a national role now to implement, but every county is able to domesticate. Even as we set up the community-based isolation facilities, this will be established within the county system. So just a few comments to clarify.
Thank you, Dr. Maritim, for your input in that, and thank you for the comments. Before I let Dr. Daisy Korir ask her question, maybe you can hear from George Otieno. George Otieno, just unmute your microphone and ask your question. Okay. In the absence of having Dr. George Otieno is not available, maybe you can hear from Dr. Daisy Korir.
Thank you so much, Dr. Agatha, and the entire team for the elaborate discussions. I think most of the issues that we were actually wondering about, you have addressed that these guidelines are still being developed, and some of these answers will come along the way. So I think on this part of the country, the western part of the country, MTRH already set up a small team to look at these guidelines and see how it can be domesticated locally and what would be required on the ground for both MTRH and the counties that support, or the counties that are supported by MTRH in the North Rift region. So I think we'll be consulting closely with yourselves so that we are able to know at what point we can actually start implementing this home-based isolation. Remembering that our first client in Wasingishu was actually managed from home, even though we did not have the guidelines that they are now coming out. So thank you very much, the team, for the elaborate discussions.
All right, thank you, Dr. Daisy Korir, for that. And we'd love to hear, once you're able to get any tangible results, or once you're able to get any information that you can let us, you can share, please share with us so that we know whether it's working in MTRH or it's still a challenge. Before we're almost winding up, Dr. Agatha is trying her best to address some of your questions and concerns. We can hear from Professor Gwantai again, who maybe you can unmute yourself and ask or share your sentiments.
Yeah, thank you very much once again. I still haven't gotten a response on the consenting process. That is one. The other one is, do we have a criteria for selecting the best suitable site for the location of the home-based isolation facility? Probably if it was discussed, I missed it, but I would like to understand the criteria of selecting where and we locate the community-based facility, and how far will it be from a healthcare facility that can respond quickly to an emergency. Thank you.
Thank you, Professor Gwantai. Dr. Maritim, would you like to address the issue of informed consent and whether it was put in the guidelines, and also the issue of emergency response and a facility that has been assigned to handle cases which might complicate at home? Hello, Dr. Maritim.
Sorry, I missed that. I was distracted. Please repeat the question.
Yes, the question from Professor Gwantai is about informed consent. Do we have an informed consent document where the patient or the caregiver has to sign and agree to the scope of care that they're going to provide, and in case of an emergency, these are the actions that they will take? And in case of challenges or anything that might come up in future, they signed and they were aware of what they were signing up for.
So I want to clarify that these guidelines are national guidelines. They're not like a study. They're not a research study. So I think that's the clarification, because as the guidelines, the way they are, there is no place for informed consent. So as they are, it's not, if a patient meets the threshold for home-based guidelines, then they have suitable and environments in the home as per the criteria, then they can be put on home-based isolation. But as it is, we did not make it like we are recruiting and following up and as part, like it's a study as such. So I don't know whether I missed an earlier presentation, and even Dr. Agatha's presentation had no mention that it's really like a study, it's a national guideline.
Yes.
So just to clarify.
Right. And there's also the issue of allocated or assigned facilities where the patients can seek care.
Sorry, is this in the setting of home-based guidelines? So for home-based guidelines, remember, one of the first criteria for somebody to be eligible for home-based care and isolation is they have to have tested positive. So what is envisaged is at the point where a patient is being tested and offered the test and being relayed for the results, then there has to be that process. So the isolation, the testing protocol still remains as is. And then thereafter, the implementation of where the patient is nursed then comes thereafter. So the first entry point to the care is the testing, the linkage to testing, or let me use the example of already Nairobi, where patients are already in isolation facilities in KU or KNH IDU. So patients currently who are there can be assessed for eligibility of home-based isolation and see that they meet 4 of those criteria. If they meet all of them, then they can be referred to their homes to stay and continue the isolation. And I think the key word that we should have emphasized and has been very clearly emphasized by Dr. Agatha, it's actually the home isolation and care. So the key word there is that isolation, because we know COVID is very, very infectious. So for patients who have already entered into care, then they are linked to either be isolated either in hospital or in their homes, or once we have the community-based isolation. So the entry point is you must have a test, a COVID test at one point in time, and then meet the criteria, and then you're triaged to be isolated either at home or at hospital. So as we implement, we'll get more clarity of this. And therefore, like the first assessment, and one of the requirements that we have put clearly in the guidelines is that there has to be a visit to the home to do the home assessment, or maybe a surrogate of that can be the patient to actually say that they are suitable, but we need to verify the home conditions that they are suitable for that home isolation, so that one of that criteria is fulfilled, so that we don't have people staying at home and contaminating. Yesterday, there was a webinar by the team from Seattle, and it clearly came out that patients are actually educated when they're in the triage. For example, if they're in A&E, they've already been tested. So for us, it would be at the point when they're being tested, the assessment to see whether they even fulfill, because part of your triage would be to see if they have comorbidities, if they have suitable space in their homes based on what they tell you, so that you can actually see at that point when the healthcare worker or the clinician is interacting with the patient, do they even fulfill the requirement as it is for home-based isolation. So the important thing is that education of the patient, and then now education for the healthcare giver. And as we say, the guidelines will probably be start implemented or be launched today, and therefore start implementing. So even part of what is needed urgently is even to relay to the public what are these things that we are looking for people who may be suitable, to really reach out to the public, either through mass media or through different strategies, to understand that COVID now, as it is, as the healthcare facilities become overwhelmed, will have to be managed at the level of the community, because it's not sustainable to have everybody within healthcare facilities. And many of you probably have even seen the videos on YouTube of people in KU actually dancing, having a good time, because they are largely asymptomatic and mildly symptomatic, and they're stable enough to be nursed outside of those hospital settings, but in other settings that are safe enough to contain the disease.
Okay, thank you, Dr. Maritim, for sharing that. And I agree with you. For some of the symptomatic cases, like the ones we've seen, patients being happy and jolly and being taken good care of in hospital facilities, as we think about resumption of services to elective services, we should also think about where do we put these patients. So it's true, this needs to be thought out clearly. But my question is to Dr. Agatha. Is there room, as we roll out these suggestions, I know probably you've already finished developing them and they are now in the process of being rolled out, but is there room for healthcare workers? Because I can see quite a lot of sentiments and emotions in the Q&A section. So is there room for them to send in their suggestions on how to improve and how to seal proof these guidelines? Is there room for that? And if there is, who do they send their suggestions to?
Okay, thank you very much, Rhoda. So I think a lot of the guidance is being, we've understood that a lot is changing even as the COVID pandemic progresses. And a lot of the guidances which have been released actually are interim, and day by day they're changing. I think with the last 2 months, we've had a lot of change even with regarding continuity of services. The first one, I think there'd been a circular released on stopping elective surgeries, procedures. Currently now they're back on, but there's still a challenge in how this is happening. So we have a lot that's really evolving day by day. And for sure there's room for input even for, especially within the implementation. We know a lot of this implementation will be happening as per county level. There's a lot of room for even how differently it will be done in different counties and how differently things actually end up, especially during the implementation phase. So there is room for this. The guidelines are being developed by the Standards Directorate. So there's actually contact the DG through the DG Health email. And I think when you download the guidelines, there's actually a contact which you can actually send in suggestions, which will be regarded. And I think there's actually going to be continued discussions on how to implement, especially the home-based care. There's someone who's brought up a question that they just felt really need to address this about community home-based care replacing dispensaries and health centers. I think that's, it cannot replace dispensaries and health centers. It cannot replace our health facilities as is. I think one of the critical parts you mentioned is that we really have so much. We've already noted that there's a decline in health services, even utilization of the health facilities, decline in health services such as immunizations have gone down notably compared to last year, deliveries, facility deliveries. And we know that there's still so much work that needs to be done even within our facilities. So even this home-based care is going to reduce the burden actually minimally when you realize they'll just reduce the burden minimally, because we know that there's still a lot of our health facilities are already handling quite a lot as is. So there's still a place of dispensaries and health centers which cannot undermine. They need to be catering. In fact, this is the point that dispensaries and health centers need to be catering for our primary health services, which include our child health services, our immunizations, our ANC maternity. So those are services which cannot go neglected. I think what was noted was that even during the Ebola outbreak in West Africa, was that those services fell through, led to a lot more mortality than even Ebola itself. So we need to really think continuity of services. Otherwise, we're going to end up at a worse state, state even more than what is resulting even from COVID mortality. So that's a really critical that you need to remember, that you cannot undermine the place of dispensaries and health centers. And as you're thinking of home isolation, please note that this is isolation of people within their homes. There's a community isolation facilities which are selected by the communities, and where according to what guidelines that community can come up with to how to manage that, to help in managing that, especially with the assistance of the healthcare management in that region. So that is different from what is mentioned as a home isolation. So I think we really need to stress that it cannot replace dispensaries and health centers in terms of services. There was also a question brought about regarding breastfeeding women. I think I will just say in the words of Prof. Noti that I think breastfeeding is really critical for children. And I think even the guidelines have taken note of that. And breastfeeding women with COVID should still continue breastfeeding. They should still take the other measures such as hand hygiene and even putting on a medical mask when breastfeeding. But breastfeeding is still encouraged and should continue as much as possible. Thank you.
Thank you so much, Dr. Agatha, for finding time to come and address this issue. And as you've heard, there's still room for giving your suggestions, because I'm seeing a few suggestions about renting an hotel, about, there's somebody who's asking about truck drivers who are in Busia, yet they come from Mombasa County. So those are some of the issues that, maybe you can give suggestions to that team and they can factor them in. But in the meantime, let's support them as they roll this out. It is not an easy task, as most of you have highlighted, especially in the setups where they would love to roll it, to pilot it. That is in Nairobi County and in Mombasa County. I wish Dr. Sood was here to share the Mombasa County experience, but we appreciate it is not an easy task. It requires a lot of multi-sectorial approach and partnerships from everyone. In this case, I think all the ministries have to be involved in it and to jump on board to support the Ministry of Health to implement this. And also, as we advocate for facility-based care, let's think about the issue of cost of care, because that has come out very clearly. The issue of cost, how much does it cost to take care of a patient in a facility, and this patient is not necessarily symptomatic? That space could have been used by another patient, or we could have focused our energies as healthcare workers in managing the other issues of health that Dr. Agatha has brought up. I'd also like to encourage the public health experts in this forum that this is a time to be on the table that discusses about urban planning. I know probably there are plans that have been drawn. They were drawn so many years ago, but maybe this is the time we participate and sit on the table that decides on housing plans. You can see it's affecting us now. Initially, probably we didn't think it would be a big issue, but we can see that now when we are having this critical conversation on accessibility and quality of housing, it's something that we need to, going forward, we need to be very keen on. So maybe I can get 2 more comments, maybe from Agnes Gishogo, Geoffrey Chepkonga, and Joseph Sifuma. Unmute yourself and you can ask your question or share your sentiments. Okay. All right, so I think we'd love to end this session there. Dr. Agatha has taken note of all your questions, there are quite a number, all your concerns, and also Dr. Maritim and Professor Nzala, who are part of the team, have also noted them. Thank you so much for attending this session. Thank you for making it lively. Thank you, Dr. Agatha, for finding time to come and share this with us. We've learned quite a lot. We saw them on TV yesterday being highlighted, and now we are happy that at least you've come to tell the healthcare workers what to expect. In your counties, please remember to share this with your members of your team, because you'll be expected to roll it out at the county level. So it's good you share, they give their input probably through the right channels, how it can work, where it can work, if it cannot work, then what options do we have? What are the risks that are involved at the county level? So those are some of the things that we need to look at. So home-based care, isolation, and care is it's ours to carry. It's not for the Ministry of Health. It's our baby as all healthcare workers, whether you're a pharmacist, whether you're a dentist, whether you're a doctor, a nurse, a physiotherapist, occupational therapist, nutritionist. This is our baby. And it's time we support the ministry in delivering this mandate. So thank you for listening in. Have a good afternoon, and we'll see you tomorrow for Mental Health Thursday. Thank you very much for attending this session. Bye.
Thank you, Dr. Kalondu. Bye-bye.